Matthew Holt, another THCB Spotlight. I am meeting here with John Zutter. John is the CEO of Lantern Care, which is in the business of managing specialty care and centers of excellence for employers. And in fact, John, very recently you guys changed your name. What was the name before? Which probably gives people a hint as to what you do and what you came from. And tell us a bit about what Lantern does now.
Sure. So the company was founded as employer direct healthcare. Our core product was Surgery Plus, um, founded about 10 years ago. And our goal at the time was to provide center of excellence services largely in kind of the traditional approach to centers of excellence, meaning travel for a limited scope of services. Um, we fairly quickly pivoted to realizing that the path to success in the specialty network and surgeon or centers of excellence space is being able to drive utilization and engagement. And to do so, you needed to cover more things for more people in more places and have a geographic access that was convenient for the ultimate membership. To solve that problem, we really needed to figure out how do you assess excellent quality doctors, surgeons, and other specialists, as well as the facility and the anesthesia provider, so that you could cherry pick on a more geographically distributed basis. And that really became the foundation for our separation from some of our peers in the category. And I think you've talked about this in some of your work, Matt, that centers of excellence have been around for a long time. They haven't always been successful. A big part of that is because of narrower scope and lack of access. So we tried to solve those two problems with more geographic distribution. From more geographic distribution, you can cover more things because you don't have to amortize the cost of that travel as much. So you can go lower in the acuity continuum. And that created the foundation for our growth to be able to work with both nationally distributed employers, but also more geographically concentrated ones. And then over the last, call it 8 years, we've continued to ramp and grow that. Today we have, by an order of magnitude, the largest network in the specialty care space for surgery, with about 600-ish locations where we can send people, both ambulatory surgery, hospitals in the community, and national institutes. And then over the last 2 years is when we've really started getting into product expansion. We launched our cancer product about 18 months ago, and then announced our launch into the infusion space, both at home and on the ambulatory side, earlier this year as part of the rebranding. So with that rebranding, we went from being a narrowly focused surgical center of excellence to a specialty care platform. And we've also seen an expansion from just the ASO space into the health plan. And we didn't want a name that didn't speak to that. And we didn't want a name that suggests we were trying to disintermediate some of those other ecosystem partners that we have to work with, not against. And so that was the basis for the rebrand.
All right. So now your Lantern, let's flip it around. What is the problem that you're fundamentally solving that employers have not had solved by the health plans or whomever, all the different point solutions they've had work with so far?
Yeah, I think
Why are you around? Why do you exist? Why do they need you?
the three areas that we're in, surgery, cancer, and infusions, represent almost 50% of the cost of healthcare. They tend to be growing at about 15% per year. And so when overall healthcare is growing at about 8 and half of it's growing 15, just arithmetically, that means the majority of the growth is coming from our categories. So one, you've got a growth and an inflation problem. Second is that there is variability in cost and quality. You put out a piece earlier this year talking about what can we do about healthcare, and you had four different assertions, right? One of which was, can you do things for less price? Can you kind of shift from a high cost to a more efficient? That's the problem we're solving, and
Right.
that's what we're executing against.
Yeah, that was always good reason to not do a tweet and then think, I really should write that up. Because I think it took me 3 years to write that up, but that is the point, right? There are various ways you can play with cost, but that's kind of one of the obvious ones. So now, tell me a bit about how you see the employer market. I've been very rude traditionally. I inherited from my colleagues Bob Lightman and Ian Morrison 30 years ago. They used to say that employers were confused, cranky, aimless, and spineless when they were dealing with healthcare costs. And you've never seen in my opinion, you haven't seen employers throw their weight around as much as they could have done in healthcare. It's always been an issue, and it varies dramatically between large employers and high wage employers versus low wage employers as to how they approach managing healthcare costs. But what sort of share of employers do you think are sophisticated enough to have the conversation with you? I mean, and what sort of level, what share of the market, could you get to? And of that share of the market, how much are using you or someone like you?
Yeah, so great questions. According to the Business Group on Health, about three-quarters of employers in that survey would put centers of excellence in their top three priorities for this coming year. So I think there's a broad focus on it. There is also a little bit of kind of solution category debt in that it hasn't historically always worked, and so we're working through that. There is a range of employers out there, as you note, right, in terms of how prescriptive, how progressive, how aggressive they might get with respect to their solution design. That's definitely changing, and this might surprise you a little bit. A number of years ago, I think in our book of business in 2018, we had one client that mandated the use of the network for a particular procedure category. At the beginning of this year, it was 20% of our book of business. Of new bookings this year, it's over 50% of clients, and they're starting that way, which is also a very significant change in behavior. Historically, you'd start option with more of a carrot-based incentive model, and then potentially move to more prescriptive things as you kind of got your population used to it. And also to the point you made earlier, depending on higher or lower margin type businesses. But when you see 50+% of clients across industries deploying more prescriptive strategies right out of the gate, I think what you take away from that is we're kind of at a breaking point where a number of the historical levers that employers in the ASO market tried to pull, they're just depleted at this point. There's no more risk transfer to the members. Transparency tools have largely not really done very much. Most of the virtual care to try and change some of the care pathways for ER urgent care utilization, as an example, haven't significantly driven any material results. And so I think one of the few things that does work is if I can have a procedure done at 50 to 60% lower unit costs and do it with materially higher quality standards, that's immediate ROI every single time that those engagements happen. And so forgive the play on words, it's a very surgical approach in
Right.
that it's a very small percent of people that use these services, but they drive the majority of the money.
Yeah. I mean, I think the one thing that, hasn't been tried very much, and some companies have done it right, is to essentially do the primary care in-house and have them build your own staff model HMO, essentially, have primary care in-house and have them try to manage the network effect. But you probably still end up with the same virtual approach, not virtual, the same approach, which is you have to manage that specialty care spend and get people to the higher quality, lower cost plans.
And there's definitely this thought process, and it's been around for a number of years, that if you go upstream, you solve downstream,
Yeah.
right? And so the upstream being primary care and the general health and well-being of your population, and then you reap the dividends over time. Two issues that play there, and there are some proof points that are positive. Our most successful client is a Fortune 500 mining business in the western part of the country in a very remote and rural environment. They use on and near site clinics.
Yeah.
Those clinics act as primary care longitudinally for over 60% of their population. And we work very closely with those clinics, and we are the downstream recipient of the steerage from those clinics. And they do 10x the utilization of an otherwise normal client. And so when you have concentration of population, those things work really well. When you have fragmentation, it becomes really hard to
Sure.
scale, right?
Sure.
We have companies like or large distributed retailers as employers that work with us, and it would be very hard for them to deploy that strategy. They've tried to put primary care into the CVSs of the world and hasn't caught on as much as we'd like it to. And so I think ultimately where a lot of employers are going is saying that's a philosophically appropriate approach, but the practically efficacious one today is forced steerage on the few things that really drive results.
So let's talk about what your business is. So first off, from the employer and employee perspective, what actually happens? So I go to my doc. So typically, right, if I have insurance, my knee hurts. I go to a doctor, I make it refer to a different specialist, I make it straight to a specialist. My insurance says, oh, you can go to, yes, you're covered by this. And I kind of off in a world, and the specialist starts fighting with the insurance company about prior auth and what they can do, what they can't do. But the employer may be involved, but isn't that involved. So what someone signs up with Lantern, how does I, an employee, what happened? What do I do? What happens that's different for me?
Yeah, so let me give you two examples. One
Yeah.
would be kind of the optional incentivized carrot-based model, and one would be the more prescriptive steerage model. So for most of our clients, what they do is they try and drive engagement by waiving deductibles, waiving co-insurance, providing cash rewards, HSA or HRA rewards. So there's a financial incentive to change behavior. Every employee that is signed up for the benefit automatically receives our benefits. So when they do open enrollment and they sign up for their health benefits generally, we're automatically in there. It's not an opt-in, it's an automatic get. So now they receive an ID card from their primary insurance. Maybe that's United, Blue Cross, Cigna, Aetna. They also will receive an ID card from us, from Lantern. So now that card's sitting in their wallet. That is both for operational purposes, but it's also a reminder that when they have those needs, they have that service. That member will receive communications from us throughout the year on a just programmatic basis. When we have access to data, we'll do targeted and focused marketing to people, at the point in time that's appropriate. But that person then engages with us. So you might call us, Matt, and say, "Hey, my knee hurts. I need a orthopod." Maybe you've already seen an orthopod and now surgery is real, and you're kind of considering your choices. You say, "I was told that I need a surgery. Can you help me with that?" At which point we're going to identify a doctor bespoke to your needs in your community if possible, or as close as proximate when necessary. So quality first, is that the right doctor for your particular use case? Contracted through us, so at favorable prices, and then we're going to give you concierge care through that journey. Human first, tech enabled. And so we're going to explain to you how we choose doctors, explain to you the costs, explain to you your choices, explain to you the benefits from both a financial and experience perspective, help you transfer those medical records, help you book those appointments, check in on you before and after, make sure it went okay. Then we're also a TPA by licensure. So on the tail end of that journey, after you've had that, call it a hip replacement, those providers are submitting their claims to us. Those can be bundled payments. Those can be reference-based payments. We can work in a variety of different payment modalities, value-based care modalities, but we're doing so at a substantial discount relative to commercial reimbursement rates. Those come through us. We adjudicate them. We pay the providers, and we, similar to the primary administrator, would invoice the employer. So we work as a kind of parallel insurance provider, technically a third-party administrator, not insurance, but a parallel provider and network for that employer to engage. So that's the optional model. In the mandatory model, the only difference would be that for select categories of care, which would typically be bariatrics, that's the most common. Joints would be the second most common. Spine would be the third most common. In those three categories, or potentially others, but those would be the most common, the employer turns off the network through their primary administrator and makes us the exclusive network. So when that member needs to engage for a knee replacement, we are the only in-network solution, which means we'll capture, near 100% utilization of those. For all the other categories of care, and this is an important differentiator between us and traditional centers of excellence, most centers of excellence are just joints, spine, bariatrics, cardiothoracic, and kind of that's the lion's share of what they do. We cover basically all plannable and medically necessary procedural care. So GYN, hernias, GI procedures. We even do things like colonoscopies, ENT, so septoplasties and eustachian tubes, things of that nature. So a much broader scope. Those will always be optional, but the big ticket items, employers can kind of turn that lever of, is it mandatory or not? And obviously the utilization results will come more or less depending on that design.
And then some of the companies who are sort of in, I would say, in this space, but do other things as well, have talked a lot about, turning, I don't know, hips a bad example, but turning knee surgery or back surgery, let's do physical therapy instead of doing surgery and that kind of stuff. Are you at the point where someone's going to have the surgery, or are you also trying to avoid surgeries and that kind of
No,
stuff?
100% avoidance of surgery is the highest value thing we can do.
Okay,
The majority of our clients, in fact, pay us on a percent of savings
right.
basis. And there's no greater savings than not
Sure.
having an unnecessary procedure in the first place. So we're incentivized for that. Our clients are incentivized for that. In spine, we tend to see north of 30% surgical avoidance when we are the second opinion. So
So
when
how do you,
someone
so how does that part work? Because that, I mean, typically by the time I've got to a surgeon, the surgeon wants to cut. Maybe the surgeon wants to cut a lower price. But other people, people like Hinge and whatever are managing this from the front end with physical therapists. What kind of things are you doing to manage that process?
So one point of clarification, then I'll answer your specific
Yeah,
question. The point of clarification is when we take credit for an avoided procedure, it is only when we are the second opinion and you've already seen a specialist who indicated that you needed that
yeah.
procedure. That's documented. Then you see our doctor, and our doctor says, no, no, no. You're not appropriate. You're too high risk. That's not the right surgical intervention. You should do physical therapy. You should take conservative treatment pathways. So want to clarify first, we only attribute value to when we are in fact a second opinion. But how do we make sure we're doing appropriate care? Um, we have a very rigorous provider selection process that doesn't just look at your training and it doesn't just look at your outcomes. It also looks at your protocols for appropriateness. Um, and that's things like, factors that, for example, don't show up in a single prior auth rule that I'm aware of. Things like nicotine cessation. Turns out that if you are an active nicotine user, your probability of wound healing complications after a surgery are geometrically higher. We require our doctors to test for that immediately prior to a surgeon. If they don't have that as part of their protocols, they're not in our network. So we go above and beyond in the selection criteria and the ongoing monitoring of our doctors around what are their protocols for surgical optimization and surgical avoidance, because at the end of the day, that's the most important thing.
So who's providing, if you're saying I'm 30%, I'm turning you away from this and I want to have do physical therapy or whatever else, how does that get provided? So as a employee, as a consumer, and I show up and now, the first doctor said I want to slice you open. The second one, I go to a Lantern doctor, they say no, it's not appropriate for you. You need this other course of treatment, you need this other type of care. How do I get that?
Yeah, so our care advocates are trained to help steer within their ecosystem or within their network as well. So we partner with a number of the leaders in that space. So we partner with Hinge Health, for example, very closely. We partner with Sword, and we can steer to those when those are in place. When they're not, we will steer to local physical therapy
I
that
see.
is within the network. Um, we will steer back to existing solutions, whether that's a Navigator we partner closely with, Accolade, Quantum included, Alight, et cetera. So we'll work with the ecosystem when it's there. When it's not, we'll navigate within the network that the person has to make sure that they're getting to what they actually need. And we try and have that really be a core tenet of that concierge service is make sure you're helping the patient with their needs.
So if you think about that, which is great, right? Some of those companies you mentioned, right, obviously are sort of in the same kind of space. I remember years ago being an included, well, when it was called Grand Rounds, and they were showing me we have we understand the local network and we know who the better doctors are and we'll take care of all of this stuff early and we'll avoid a lot of the back surgery, et cetera, et cetera. Why does a company like that or Accolade, which is in the navigation business, why do they need you as well? Why aren't they doing this themselves? And how
Yeah.
do you partner with them as opposed to as opposed to being a competitor to them?
No, it's a great question, and I think we're highly complementary, not competitive. In fact, those organizations are uniquely capable of top of funnel engagement,
Yep.
right? They engage with a very substantial number of the members over the course of the year. They create continuity in those relationships. They can identify needs before we can, right? We're the end of the funnel. They often have more robust access to data. just given the nature of their business model versus ours. And so they're very good at identifying the patients that need that care. What they also, to the point that you made, they often have great intelligence of who are the better doctors, who aren't. But what they aren't is an administrator. What they aren't is a direct contracting agent that can actually change the unit cost itself
Mm.
through different payment modalities or just through lower reimbursement rates outright. And so they're the top of the funnel and we're the bottom, and we perfectly complement each other in that I know exactly what to do with the member when they call us. We just are desperate for more calls. And they get an enormous amount of engagement at the top, and then we can really help steer and fulfill that in the most efficient way possible.
How many, and while you're talking about those sort of navigators, the quantums included, how many of what sort of share of overall market? And was back to like how big a deal is this? And this will become important in the next set of questions. How big a deal is this in terms of how many employers now are sending people via those kinds of navigators, and how many of them are sending? If you have, I don't know how many
Yeah, so
employees there are. How significant is that for you?
we are about 6 million member lives for next year, for the beginning of next year, a little over. Of that, I don't have the exact number, but my guess is 25% of it overlaps with one of those three
Yeah.
navigators. And that number is growing. Both the navigator space is growing and our space is growing.
Yep.
We, I think, disproportionately reflect that growth in our space, having won the vast majority of competitive engagements this year, the vast majority of competitive lives, things like 32BJ, which represents another kind of validation of our offering vis-a-vis alternative pathways for employers. 32BJ historically had direct contracts, but their people aren't all in one place. And
Yeah.
so, how do you make sure you're giving a consistent experience for the same set of services across geographies becomes a challenging problem for large employers, and we're able to kind of pull that together at scale. Um, and so um, I think both navigators will grow along with centers of excellence. Centers of excellence are clearly a beneficiary of the current healthcare and macroeconomic environment, though.
But if you're at 6 million lives, and I don't know how many, if you bundle up all the navigators, it's in the low tens of millions, I would guess. And there's what 150 million people getting insurance for our employers at some stage. So you're still a small, relatively small chunk of the overall.
Yes, our capture rate today relative to the total opportunity is not enormous. Um, but we are adding a couple million lives this year alone,
Right.
right? And so that rate of acceleration is still, in kind of the vertical slope. Um, and we're really excited about a couple of things that create accelerators for the broader market space. If you had asked about our ability to partner with health plans and other kind of indirect distribution pathways, aggregators, et cetera, convening agents. A number of years ago, I would have said that seems unlikely. Um, and today, we are part of the UHC vendor hub. We are having very constructive conversations with a variety of the different health plans to be part of go forward solutions. Um, and I think that's both a representation of employers pushing, but also a reflection of kind of where we are in the industry at large. And I think part of the ramp that you've seen with some of the solutions that have really become pervasive, right? And you think about elements of telemedicine, elements of virtual physical therapy that have really ramped their membership to be a significant portion of the U.S. healthcare system. It's through that indirect distribution. You can't do it one by one, but often innovative and disruptive pathways have to start in the ASO market and then work their way into the other channels as well.
So let's talk about that part, and then let's talk about the impact on the overall system and hospitals. But for this part, I mean, the obvious question is if I'm United Healthcare or I'm, a Buka, these guys are already in my network, aren't they? Shouldn't I already be able to define where people go? And why would I need you? Why would I need a lantern to help sort of find that? Is that because you've done the work in terms of figuring out the best but cheaper alternatives for surgery or what have you, or infusion that they haven't done or they can't do, or is this a big bureaucracy problem, or is this that or is this something that they're experimenting because they've had demand and it's easier to get it from you than to build it internally?
I think that it's actually structural
Yep.
in that the customer, being the ASO customer, the fully insured employer, uh, the population at large, still wants an open access network.
Yep.
And so when you want an open access network, the carriers have to contract with the substantial majority of providers out there. And once they have that as the core kind of foundation of network design, it's very hard to then overlay a steerage model on top of that. And so um, I would never assert that we are better at contracting or have more intelligence or data than the large carriers do. That clearly wouldn't be the case. But what is the case is they're providing a service that everybody wants, which is includes broad open access networks. And as a result of that, we can provide a complement on the kind of narrow, highly focused specialty care components of that in a way that is um, incremental and beneficial to the end user, to the patient, and to the health plan itself.
Yeah, no, that's where I kind of thought you were going. And it's the bureaucracy, stupid. It's very tough for them to do both, and it's probably easier to contract that out. Which is, and you have seen examples of them. I mean, and the most notable one is United tried to build a parallel diabetes program effort to Livongo. I can't remember, which is still around. I can't remember what it's called, but it's they try to build it. Sometimes it just doesn't work, and they have to contract with the one that's out there. So let's flip over to the other side of the house, right? With the other side of the house, the other side of the system, which is the people you're buying from. There's a, you know, I have this thing. There are a couple of there's the Health Rosetta group, right, which is Dave Chase and his gang who wander around and talk about how they always say, "Oh, we can do direct contracting," and it always seems to me that they've got the Pittsburgh School District and they've got the Rosen Hotels in Orlando, and once you get past those two success stories, there's not many people around. And a lot of that I think is because, you're buying on the margin in some ways. And if you become, you can control some people and you've got some buying ability if you're in a particular small region and you can go buy. But if everyone tried to do it, the system would revolt, and at some point this must be cost shifting to others. So I guess the question is, you're doing this on a national scale. You've got a lot of people on your network. I mean, how much when you go to one of your chosen providers, uh, are you enough for their business from the care about? Are they just happy to get some business on the margin from you? And what happens when you grow enough that you become really noticeable? Does
Yeah,
this start
this
actually?
is a fascinating one. I had a conversation with a senior health plan executive um, that asked a very similar question and said, "Okay, so I get it. Incremental marginal utility. You're bringing a couple cases. They're willing to cut a cost, but once you get bigger, like they're going to turn you off." And I said, with all due respect, I violently disagree because what we're doing is we're actually introducing a different structural capability, right? Which is we're reintroducing market dynamics in an industry that often does not have those at the local or regional level. And so, like, let's just play that out for a second. Most cities across the United States are highly oligopolistic from a provider system perspective.
Sure.
And so there might be two, there might be five, but there normally aren't 50.
Yep.
And each of those has whatever their market share is. And each of those often will have great specialists and they will have less than perfect specialists, and it's a distribution. Um, if we start from an incremental utility perspective and grow to the point that we're actually materially changing overall healthcare costs, that also means that we just became significant. It also means we just became a important portion of the revenue stream in that market. And so you can imagine the situation where, like, if you are the healthcare executive and you call and say, "Hey, John, this was supposed to be an extra case, and now it's really cannibalizing, my overall unit economics." When you say, "Oh, excuse me, hold on, your competitor's calling on the other line." Because the moment that it has materially impacted the overall unit economics, it's also relevant for everybody else as well. But more important than that, the math that we show is not that this is a zero-sum game and that it's a race to the bottom or who's willing to take the loss type of dynamic. In fact, it's more accretive because again, the value of steerage offset against um, that unit cost reduction when you can broaden geographic catchment area. Um, the math tends to be that it is actually a creative business. We've done this analysis for some of our hospital partners, and typically about 80% of volume for a hospital comes from that zip code or the immediately adjacent zip codes. We are very different from our COE brethren in that only 2% of our people get on a plane to access our network. So 98% are within a drive. Average distance last year is about 25 miles. But 25 miles is probably twice the geographic catchment area of most hospitals. So they're getting patients they wouldn't otherwise have, and they're capturing an incremental market share in that market itself. And that more than offsets any unit cost reduction that they have. The practical reality is every hospital has vacancies. And if you can fill those vacancies above their marginal cost, that's good business. And we are always paying a premium to their lowest cost reimbursement rates, meaning Medicare and Medicaid. And so, provided that we can bring incremental patients, broaden geographic catchment area, shorten payment timelines, meaning we increase working capital efficiency, and we also eliminate the bad debt associated with member bills, where since that's waived, they don't have to chase that obligation. So that's improving their capital efficiency as well. So it's actually a win-win, as much as it might sound like it's adversarial to each of these counterparts.
Well, that's interesting. I mean, and I guess if it gets big enough, right, eventually it'll start doing what we've been talking about forever, which is steering people to the lower cost, higher quality. In general, most of the data shows that lower cost and high quality go together, and it's the people who are screwing up, not doing enough surgeries, charging too much, having to do them again, having to repeat readmissions, and the rest of it that you're trying to eliminate. And if you can, higher quality is usually,
Yeah,
is
it's
usually
healthcare
ends
is
up being lower cost.
absolutely. Healthcare is one of the unique industries where lower cost is often correlated with better. Whereas that's part of the problem with the entire premise of so many of the transparency focused and consumer focused initiatives out there is that healthcare itself is a dynamic that is often the reciprocal of normal market forces, where in almost everything else in our lives, more expensive correlates with better. And in healthcare, often that's the exact opposite. And so, that's one of the contributory factors as to why, many of the consumerism models just haven't been that effective.
Yeah, I have a chart which I use sometimes of, I think it's the Dartmouth School, which has everything. It's cost and quality by state. If I recall, I think the lowest is Louisiana. The highest is top left is Hawaii, and bottom right is Louisiana. And then I do sort of cost and quality by hotel. And I have bottom left is Motel 6 and top right is the Ritz-Carlton. Like it's just completely the wrong way around,
Yeah.
And that has been the case. And I think that what in some ways, what you're doing at Lantern, if you were to put in the macro, is sort of operationalizing the ability to figure out that and to help do using the steerage to do that. And obviously, people have done it with reference pricing and try to do it with all different types of other approaches. It just hasn't been very effective, And I think you can go back to I think it was a while back, but New York State was recording quality of care for cardiac surgery years ago when Bill Clinton had his bypass. He ended up at the lowest quality hospital. You think, well, surely somebody in his team could have read the report, but apparently no one
Well,
bothered.
it's not just not reading it. I mean, you're striking a chord on a bunch of work that we're focused on here every day, which is how do you really understand where the cost and where the quality dynamics are? And the reality is, as much as regulation and market forces are trying to make things more transparent, they often um, don't lead to the intended consequence. Right? Machine readable files don't necessarily tell you perfect visibility into what things cost because it's more nuanced than that. Site of care changes. We see a bunch of dynamics where how people bill, the behavioral practices in billing is not consistent. And so it takes a very granular view, and we benefit from being a payer ourselves, right? Being that third party administrator where we adjudicate claims, we get to see these behavior patterns change. But many of the tools out there, they struggle to keep up with how those behaviors are changing and really understanding what your costs are. Like employers often will say, I don't have access to my data. Well, that's the first of many problems. But if you had access to it, is the data clean? How do you interpret the data? How do you aggregate things that are not always so obvious? And so being able to really understand that allows us to have a differentiated impact.
Yeah, and I think that that general pattern of employers saying they can't get access to their data and having to sue health plans and unions suing health plans and that's all start that you can see that starting to come through the legal system and with the change to the and I'm blanking on the name.
Fiduciary.
Thank you.
I was saying that some of the fiduciary claims.
Yeah, saying the fiduciary claims and there was a bill passed which included that in 2 or 3 years back, which I'm blanking on the name of. Brian Clapper will come on and spank me for not remembering it. But the point is that you have to look at that employers now are being sued by employees for not caring about drug pricing and this kind of stuff. And there's going to be more and more of this. And at some point, the big plans and the big hospital systems will really have to do a better job of presenting what's going there. And maybe, I'm not big, can't say I'm a fan of the incoming administration, but maybe, their interest in transparency might move us towards more of that as things come. We'll have to see, of
No,
course.
I think that there's an age-old maxim, which is something along the lines of, uh, if you tell me the incentives, I'll tell you the behaviors. And um, none of the behaviors are particularly surprising, right? And they align with incentives. And so I think often when you're doing the data analytics work, you have to also put yourself in from a place of empathy and into the mindset of the counterparts. What is in the best interest of the hospital? What's in the best interest of the insurance company? What's in the best interest of the employer, the patient, and all the different steps in between this highly fragmented industry. Um, and that layer allows you to kind of better dissect what might really be going on because it's often not what it first appears.
Right, right. All right. No, I think you're dead right. I think there's a lot. I mean, we're going to spend well, spend the rest of my career and the rest of yours probably, figuring this stuff out, hopefully getting somewhere. I mean, the system has, as you know, been incredibly resistant to change, and there are going to be multiple different levers which we're going to have to try to pull. And the last 30 years, not a lot has worked. So maybe this approach will be one that might do.
And I think
Right.
the reality though is that there's an pressing need to figure out this problem set because there are emerging problem sets that are huge, that are right on or over the horizon. The amount of drugs in the cell and gene therapy category, for example, that
Right.
are going through the um, testing and approval processes and what their ultimate cost will be is going to be an enormous challenge. Infusions is a space where the cost differential for the exact same drug administered in one place versus another can be orders of magnitude
Crazy,
different.
crazy. Yeah.
Um, and one where quality is not always the determinative factor of why that price is so different. In fact, often it's
Inverse.
um, upside down. So
Yeah.
we got a lot of stuff to focus on. We got to stay focused, but we got more problems after this one.
And don't forget, we still have GLP-1s, right? Which more than half the country theoretically should be eligible for, costing 12 to 15 grand a year each. My solution to that is simple. We just invade Denmark. Cap,
It,
capture Novo Nordisk headquarters, take it over, distribute it for free.
and the interesting thing about the studies on that is today, I would say the majority seem to indicate that bariatric intervention is a higher ROI, lower cost, higher
Yeah.
effectiveness. But that's really because of current side effect profile. And the right answer long term is probably a combination of pharmaceutical therapeutics, behavioral modification, and anatomical modification. I think in the short term, you probably see more bariatric surgeries, and in the long term, much less. But it's certainly a place of dynamic change.
Don't worry, RFK Jr. is going to take high fructose corn syrup out of Coke and replace it with sugar, and that solves the whole problem. Basically, maybe you do see all these things on TikTok and Facebook of beaches of people in the 50s and 60s, and they're all very skinny. But and so
Yeah.
there is something to be said. As I said, I'm not a big fan of the new administration anyway, but something to be said for thinking about how we manage the food chain. And people have talked about this for a long time. It just hasn't
I,
happened. But anyway.
I'm certainly going to stay clear of politics. That having been said, I think the concept around gut health and um, nutrition and its impact on healthcare is a significant one that warrants a lot of attention for
No,
sure.
obviously, and and there's going to be a lot. The means, I think it's a brother and sister. The means, the means folks who are involved in, with them have been talking about this. It's very interesting when you think about where we got to, and I liken it. And now we're completely off topic from what you do. But I liken it to smoking, right? When those photos of people were taken in the 60s and 70s, everyone on the beach was smoking as well, right? And now very few people are smoking because we had a sort of 30, 40-year campaign to both tax it out of existence and also show to people how bad it was for you. And we've had a reduction in lung cancer deaths, as a consequence. Meanwhile, around that time, back in the 60s, 70s, we started messing with the food,
Yep.
the food and nutrition chain, and you saw in the 80s and going through to now, this big rise in obesity, and these things are not unconnected.
Yeah,
Having
and
said that, expecting the healthcare system alone to fix it is a big deal.
I
All
think
right, we should stop there because we could go on this topic forever. But let me just finish up with the company, John. So you guys raised another 92 million from Insight and Friends. Was that late last year or earlier this year? I forget
so.
when
We
that
did a
was.
secondary where Insight joined our cap table at the end of last year, which is the transaction that you referenced.
Okay.
And they've been a great partner to us.
And then how much you guys raised overall? And just give me a flavor of where the company is now in terms of.
Primary and secondary, well over 300 million.
Okay. And then give me a sense of and how you get paid. You mentioned earlier you get a share of savings in some cases. Is that what's the traditional when you show up to an employer, what's your traditional sort of how you pay me business model?
Yeah, we are agnostic. We have clients that pay us on a subscription fee PEPM with guarantees. We have clients that pay as a percent of spend, a markup. We have a very large percent of clients that elect to do a percent of savings. In the last number of years, that has been where the market has been most focused. We have a few other payment modalities. So generally speaking, so long as we win when our clients win, we're flexible.
And what kind of growth are you mentioned the growth in the number of lives. What kind of growth in revenue are you looking at the moment?
We've had the good fortune of growing pretty close to 100% a year since I've been here.
That's I'm sure Scott Barkley will be happy to hear that, among others, as well as hoping that Spurs win the Premier League one day, which is less likely to happen. Anyway,
Mhm.
all right, fantastic. And then give me a flavor. How many employees at the company now?
We are around 650, including both W-2 and dedicated contractor employees.
And then the question I always have to ask, because you raised a lot of money, and eventually those nice people from the VC and PE funds want it back. What's your future sort of outlook for when this might be IPO or when the company might transform somehow? What's your expectation when we might see another transaction of some kind?
We had the good fortune of being profitable today, so we can control our destiny. I'd say this probably isn't the answer you're looking for, but I'm just focused on building a great business, and with that creates a lot of optionality. I think we probably would have choices today if we pursued them, but we're focused on the long term. Our investors have each put capital into the business recently, and there's certainly no rush from anyone around our side.
All right, so we will not be looking for your S1 anytime in the next couple of weeks around JP Morgan, but there'll be a few others coming out. You mentioned a couple of the companies involved that
You will definitely
claim they're going to
not
have
see
them.
our
We'll
S1
all
at
be
JP
looking at
Morgan.
those with great interest. All right, but not you, but not the one from Lantern. All right, we're speaking with John Zutter. He is the CEO of Lantern. John, thanks for your time.
Thank you. Bye.